please start.
I'm Dr. Vishal and this is Dr. Sandeep. We are team number 13 from Nizam's Institute of Medical Sciences. We are presenting a case on lower one-third leg defect. A 40-year-old lady hailing from a remote village and a homemaker by occupation presented to the OPD with chief complaints of wound with an exposed implant over the lower aspect of the left leg since 20 days. History of presenting illness. The patient was apparently all right 2.5 months ago when she gives a history of slip and fall from the stairs. She sustained an injury to the left lower limb and was diagnosed with a lower one-third both bone fracture. She was initially managed with splinting and bandaging by a quack for 30 days, and she was able to ambulate for daily household work with this management. The patient then gradually started to develop increasing pain and swelling on walking or standing, for which she visited a hospital. She underwent open reduction and internal fixation at a private hospital on 18/6/24. 20 days post-operatively, she noticed skin discoloration and purulent discharge from the wound, followed by gradual opening up of the wound and implant exposure. This was managed with regular dressings. Past history. The patient is a known hypertensive and is on medication since 1 year. And treatment history, post-trauma, she was managed conservatively by splinting and bandaging for 30 days and underwent open reduction and internal fixation on 18 June 2024. There was no significant personal or family history. General physical examination. The patient is moderately built and well nourished, oriented to time, place, and person. She had stable vitals with a blood pressure of 130 by 80 millimeters of mercury and a pulse rate of 80 beats per minute. There was no evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy, or generalized edema. The systemic examination was essentially normal. On local examination, the patient was examined in the supine position with the hip extended, knee extended, and ankle in mild plantar flexion. There was a wound of size 8 by 2.5 centimeters over the medial aspect of the lower one-third of the leg. The proximal edge of the wound was 24 centimeters below the tibial tuberosity, and the distal extent was 0.5 centimeters above the medial malleolus. Anterior-posteriorly, the anterior border extended 0.5 centimeters posterior to the shin, and the posterior border was 3 centimeters anterior to the posterior midline. The floor of the wound was found by the exposed implant with areas of granulation tissue and minimal serous discharge. The edges of the wound were sloping. The skin around the wound was mildly edematous with a linear scar extending from the proximal edge of the wound for a length of 7 centimeters. And another linear scar of size 3 centimeters was seen over the lateral aspect of the distal one-third of the leg, 2 centimeters above the lateral malleolus. On palpation, there was no local rise in temperature and there was mild tenderness around the wound. The length of the leg as measured from the medial joint line to the medial malleolus was found to be equal bilaterally, measuring 34 centimeters. The girth of the leg measured 10 centimeters below the tibial tuberosity was found to be 20 centimeters bilaterally. The inspectory findings pertaining to the size and extent were confirmed, and surrounding induration of 0.5 centimeters was palpable. The dorsalis pedis artery, posterior tibial artery were palpable, and the volume was comparable to the opposite limb. Modified Allen's test was positive. The joint range of movement was examined. In both active and passive, the range of movement was found to be normal in all the joints, that is the hip, knee, ankle, and the toes. The foot was examined for sensations, that's pain and fine touch. They were found to be bilaterally equal on the distributions of superficial peroneal, deep peroneal, medial plantar, lateral plantar, median calcaneal, sural, and the saphenous nerve. So on diagnosis, we have a 40-year-old hypertensive lady with a 20-day-old post-surgical implant exposure for distal third closed tibial fracture of the left leg with no neurovascular deficits.
With the above mentioned in the diagnosis, I would like to proceed with investigations. Initially, I would like to get an X-ray done for the patient of the left leg in APN lateral view. On the left side of the screen is the preoperative X-ray, which was taken 30 days after the injury, showing the APN lateral views of the left leg. X-ray shows tibia, fibula along with the ankle joint. There is a fracture noted of both the tibia and fibula 5 centimeters proximal to the ankle joint. And there is also an valgus deformity on the anterior posterior view. On the right side of the screen is the post-operative X-ray where the fixation was done. Later, I would like to do the color Doppler of the left leg for assessing the patency of the anterior tibial artery, posterior tibial artery, and peroneal vessels, and also for checking of the perforators arising from the posterior tibial artery. And then I would like to send the wound swab for the culture sensitivity, and I would like to do the surgical routines for the pre-anesthetic checkup. Coming to a treatment plan, initially, I would like to do the wound excision, followed by the removal of the implant, and by the removal of the implant and external fixation by the ortho team. In external fixation, I would like to put anterior and lateral pins, including the spanning across the joint. After wound excision, the size of the defect is going to be around 10 centimeters vertically and 4 centimeters horizontally. To provide soft tissue coverage of this defect, I have planned for 3 flaps. Plan A is posterior tibial artery propeller flap. Plan B is anterolateral thigh free flap. Plan C is reverse sural artery flap. Coming to our plan A, I have marked the landmarks, that is the tibial tuberosity and the mid-malleolar point. Joining these 2 points is the reference line. Parallel to this reference line, 4.5 centimeters medial to this, I have drawn another line which represents the axis of the posterior tibial artery perforators. And on handheld Doppler, there is a perforator which is 4 centimeters proximal to the proximal edge of the wound. This is the video showing the perforator. From the perforator to the proximal edge of the wound, the distance is 4 centimeters, and from the perforator to the distal edge of the wound, the distance was 14 centimeters. Considering this vertical distance of 14 centimeters and the transverse wound defect of 4 centimeters, I have planned a flap proximal to the perforator, which is of 15 centimeters in length, considering the flap contracture after elevation, and 4 centimeters of width. After planning in reverse, this is the arc of rotation of the flap. If on exploration of this perforator, if the perforator is not found to be reliable because of the previous surgery and previous trauma, then I would like to proceed for the anterolateral thigh free flap. To avoid the zone of trauma and surgical scarring, I would like to dissect furthermore proximally, which gives us a length of 18 centimeter defect with 4 centimeter transverse defect. This I have planned for a free flap, considering the landmarks, and I have found a perforator at the midpoint joining the anterior superior iliac spine and the lateral border of the patella.
The third plan is a reverse sural artery flap. In this, we've marked 2 points for the axis of the flap. The distal point is the midpoint between the lateral malleolus and the midpoint of the tendo-Achilles. And the proximal point is the midpoint of the joint line. This joining these 2 lines gives us the axis of the reverse sural artery flap. With the handheld Doppler, we've found a perforator 2.5 centimeters behind the fibula and 7 centimeters proximal to the lateral malleolus. This is a video showing the Doppler image. With the pivot point 1 centimeter proximal to this perforator point, we've planned for a reverse sural artery flap in reverse. The maximum width of the flap was taken to be 11 centimeters, corresponding to the length of the defect, with 1 centimeter extra for the primary contracture. And the length of the flap was found to be extending up to the junction of the proximal third and the middle third of the leg. This is a video of the reverse sural artery flap planned in reverse. Thank you, sir.
Okay. Regarding your first plan, your propeller flap, the upper limit reaches almost up. It reaches up to the upper third of the
Legs.
deck.
Yes.
Is it a single? This perforator can perfuse the tip of the flap? I have in doubt.
On Doppler, the signals were very good, sir. So
So the
might-
flap is very narrow, and this single perforator. So there is a range for each perforator. That depends on the pressure of the perforator. So I don't think it will. Then again, your second plan, ALT, this is a narrow defect.
yes.
The length is more. So I feel ALT, I think a graceless is better than an ALT, a muscle flap.
So
Because
we are preferring for a fasciocutaneous flap over here. Sir.
What is the advantage? You can put muscle there, and you can simply put a graft over there. In this area, I don't think any added advantage with the fasciocutaneous flap. Do you have anything?
If at all in future there is any complication of non-union or so, if at all there is any re-exploration by the ortho team, skin flap elevation is easier than the muscle flap.
Internal fixation have been done around 1.5 months back. Know the status of the bone healing now.
Sir, the patient presented with purulent discharge, and they gave a history of purulent discharge from the wound and exposure of implant. So we are
Planning to remove the implant.
That depends on the orthopedic opinion. We cannot solely say we will remove the implant. You have to take an opinion from the orthopedic side, orthopedic surgeon. Then only we can decide on that. So coming to your third plan, have you noticed then there is a healed wound on the lateral side too, the lower lateral malleolus. Do you have any problem in raising distally based sural artery flap? Because there is an injury. I think there is an injury there. Healed wound.
Sir, regarding this, we found a perforator which is proximal to the incision. So we think that we can safely raise the RSA flap since the perfusion will be from the perforator through the peroneal artery.
The perforators are good. I think it is better to do a color Doppler rather than a hand Doppler, and you can see the perforators better.
Okay.
You go for a distally based sural artery flap. Okay.
So, Dr. Sandeep,
yes.
Can you go back to your diagnosis, please? The diagnosis slide. Yeah. So can you explain the inference you get from these diagnoses actually? What are the importance of each thing? Good, my question.
40-year-old lady, she's having a comorbidities of hypertension for the last 1 year.
Can you show the picture? The first picture. Yeah. What do you see in this leg? Spot.
Exposed implant with a wound over the distal third of the leg, medial aspect, and surrounding edema and
do you see some amount of discoloration? Do you see that there might be some amount of vascular compromise in this patient?
Sir, this is probably because the patient did not clean the wound adequately, because distally we were able to palpate the dorsalis pedis and the posterior tibial arteries well. And
any temperature difference? Any temperature difference?
No, sir. There was no temperature difference between the two limbs.
Okay. Okay. So only a handheld Doppler is sufficient, as you may require to do a angiography or some sort of a Doppler studies.
Yes, sir. In the investigations, we have mentioned that we would like to get an arterial Doppler done.
Color
Arterial
Doppler.
and venous Doppler of the left lower limb. So that we can visualize the patency of the vessels and also notice the perforators.
It was a closed injury, I think, right? So they have operated
Yes,
after 1
yes.
month. Yeah, so it was a closed injury, and previously there was so you can always that's also right because it's a surgically created one.
Yes.
Yes, sir.
The diagnosis part. So did you mention there's exposed implant is there?
Yes,
Yes, a post-surgical
implant.
implant exposure.
So here you said that 20-day-old post-surgical implant exposure. So why you think that, why does it happen actually? Why did this implant get exposed after 20 days? Why does it happen? Because it was 1 month old injury. After that, they have operated, and after 20 days, it got exposed. So what do you think? What are the possible causes?
On the patient was operated 30 days after the initial trauma. So while operating, the surgeon might have not curated the callus well, and that might be a source of infection.
Incomplete evacuation of the hematoma or could have caused. And the presence is
Interesting. Now, first of all, we should know why it is happening actually. It's 1.5 months after, suddenly after 20 days, wound opened up and there is an infection. So there might not be proper surgical technique has been followed, or might be some infection is there because it was a closed injury.
Yes.
So infection has been introduced once we have opened up. Okay. And might be they have opened in a different plane. That might be reason. So what will be your first step? Are you going to intervene in the same sitting? Like, what will be your first step? You are taking out the implant and you're putting a flap straight forward, or you will be doing something else in the first stage? So what should be your first stage?
After removing the implant and external fixator in the same sitting, we're planning for the flap cover.
So you will be doing proper debridement. Is there any
Yes.
role of VAC here? Because you don't know what infection is this. Is it a bone infection or is it a soft tissue infection? What kind of infection you suspect here?
Bone.
Could be an infected callus, sir.
Yes. Are you going to remove that callus? How do you know what is the limit of your debridement? Because without good debridement, doing a flap, it's not a right idea.
Okay.
How do you ensure that your debridement is appropriate and up to the mark? Anyway, so you straightforward remove the implant, debride it, and put a flap and go. Huh? Suppose I debride and there will be I have to remove this loose segment of the bone there, and
Yes.
I found there's a defect of 3 centimeters of bone there. So will be you are going with the same plan? Because your perforator flap has a major drawback of, one is the width, and second, your perforator is lying in the scar area. If you go to the perforator planning, you can see that your
Yes.
perforator is present in the scar area. So
Yes,
how can you rely upon that perforator which is in the zone of trauma? Because it's a iatrogenic created wound, and your so do you want to change your plan here? Are you still going with the same plan first? It will be your
Yes,
plan A.
Initially, I would like to proceed with the proximal anterior incision, sir. Then I'd like to
Yes.
see for the status of the perforator over there. If the perforator
Okay.
is dissectable and reliable for the flap, I'll proceed with the propeller flap, sir.
Okay, so
If
define reliable perforator. What is reliable perforator? You said you will look for the reliable perforator. So
as there is
define what
previous
is.
surgery, sir. As there is previous surgery, the perforator should be free of any adhesions or fibrosis around the perforator, sir. Reliable perforator is generally, it is more than 1.5 centimeter, and it should be dissectable all along the length up to the origin of.
And the most important thing you are forgetting here, One more
And the
thing.
diameter
Yeah.
of the perforator, sir.
That you have said.
Yes.
It should be pulsatile.
Yes, sir.
It should be pulsatile by your naked eyes. One. The important thing here is, suppose you are looking for the perforator here and you don't find the same perforator at the same location, and you find it is little away from the flap, from the wound edge. So how will you proceed in that situation? You got me? It is at 4
Yes.
centimeters. Suppose you find it at 6 centimeters, because then now you have to change whole plan, because you cannot go
Yes.
up in the leg. So how will you modify your flap? One, or will you still go for it, or you want to change it here?
If the perforator is more proximal, then I would like to proceed with the anterolateral thigh-based reconstructions.
Okay. So you are just relying on one perforator. You did not mark any other perforator in this vicinity. And I hope this is a posterior artery based perforator flap, no?
Yes, sir.
Yes.
Okay. So what are the
Your implant is very well placed. Do you still want to remove the implant and put in an external fixator, because you don't have a distal purchase for your
Yeah.
external fixator?
This distal
Distally,
fragment
I
is-
would like to span it across the foot, sir, as the distal segment is very small.
Why you want to remove the implant?
Sir,
That acts as a source of infection, sir. Presence of an infected implant can lead to further loss of flap. And also, if we do not remove the implant, then we cannot guarantee complete debridement of the infected area. So chances of post flap cover infection and loss of flap are high.
So as Dr. Sunil had said, that you debride it, put a vac, control the infection, wait for a while, reduce the area of the defect, and do a free flap. That is a better option than doing a local flap, because it's
Yeah.
already surgically traumatized zone. It's a zone of trauma.
Yes.
okay.
And even during your first, even you say that there is some amount of vascularity compromise. That is why the wound got broken down. Why wound got broken down? Not because of the infection. Must be pre-existing some sort of a vascular compromise. In such a scenario, we should not go in for a local flap. We should opt for a free flap.
Okay.
If you see the X-ray, your implants are very well placed. Why you want to remove the implant?
The implants are
The
well
fracture
placed.
is fixed well. The implants are in position. You give irrigation, put a vac, control the infection, then plan for a free flap. Don't disturb the implant. Because if you are putting in an external fixator, again those pins which are of the external fixator will go through your perforators. That will again jeopardize your vascular compromise.
Okay.
Are you? Is it okay, Dr. Sunil? This plan?
This is okay, sir, because I think there is no need for removing the implant. Better we'll take an opinion from our orthopedic colleagues.
What will be your donor vessel?
In this, we would like to use the posterior tibial artery, sir.
Okay, that Doppler you are done up to the knee joint. You trace the vascularity.
Yes, sir.
To which free flap you said? You said the ALT.
Yes, sir.
Yes.
Okay. What are the advantages of ALT?
Longer pedicle length, sir, and thinner flap, and in defects of width lesser than 7 centimeters, it is primarily closable.
Very good. Very good.
Yeah, good. So you will be taking donor vessel, posterior tibial artery,
Yes, sir.
and vein.
The vena commitments of the posterior tibial
Same
artery.
VC of the
So
posterior
it will be end to side or end to end anastomosis?
preferably end to side, sir.
Okay.
But if at all we have to do an end to end, I'll confirm the patency of the communication between the AT and PTA before cutting the vessel by clamping the put PTs.
I think you have mentioned in your history modified Allen test is positive. Can you
Yes,
rely on
yes.
that? Can you rely on that?
Preoperatively, I'm doing color Doppler also to confirm the patency of the vessels.
Okay. So this is routine you do in all patients color Doppler to see the patency if you are going for the free flap.
Traumatic patients.
In trauma reconstructions, we generally do.
Okay. Okay. I'm just asking. Actually, every institute have their own protocols, so that's not an issue here. So ALT using posterior tibial vessel, anti-side and vena commitants. Okay. No other vein. Why don't you try GSV here?
It is always better to do the anastomosis to the deeper venous system, sir. Superficial venous system is not so reliable.
Oh, really? So there will be size discrepancy between the vena committant and the ALT vein. There's a huge size discrepancy. Yes, you can say you can do two veins, no? One with the superficial system, one with the deep system. I think that will be a better answer.
Okay.
Okay. So as we were talking about the salvage of the implant, do you know, do you quote any current literature which is saying that yes, we can salvage the implant, these type of implants? So how much percentage of implants can be salvaged by using these type of free flaps or any vascular tissue transfer? Do you have any idea about it? And in which situation we should try to salvage it?
No,
So I think this is food for thought. We should read about it. There is a few good articles are coming. Actually, those articles are mostly for the spine and then around the knee. Yes, lower limb. Yes, free flap is always better choice. Removing an implant is again a debatable issue. But if it is infected and it's pouring pus, yes, you need to sometime here because you have to again check with your orthopedic colleague that yes, this bone is osteomyelitic or not, because it's too early to say it is osteomyelitic. It's only 20 days old, but the injury was 1.5 months old. So that's the only, if you are finding any loose bone segment is there, you have to take out those segments and the bone is, and the implant is. So these are the two scenarios which you can have. So your next plan was, I think it was reverse rural artery.
Yes.
So now what will be the sequence of your plan here? Are you still going with the perforator flap first, or will you be switching to the ALT? What is your plan here now? Are you getting me?
sir. Yes, sir. Yes.
So
There is one more incision on the lateral side.
Yes.
There are one medial incision, one lateral incision, and you're going to put another incision for your flap. So there is so much amount of vascular compromise doing a local flap. You still want to do a reverse rural artery flap?
This we had considered as a salvage, sir. If there was loss of the flaps, only then we were planning on doing a reverse lateral flap.
salvage is always a best plan. That should not fail. Okay, that should be the lifeboat. So, abhi to sawal ye hai, the question here is, are you still going with the perforator flap as a first plan, or are you changing it to the free flap? One. If yes, then why?
Considering the involvement of the perforator in the zone of trauma, which I've marked for the posterior tibial artery propeller flap, I'd like to change the plan to anterolateral thigh-based free flaps.
Okay. So you are convinced with the examiner now. Okay, interesting.
Yes.
It was a trap. I say I can do a perforator flap. So please design a better perforator flap for me in this case. Can you? Is it possible for you? You go a little higher up, little proximal, look for a good perforator, and you change the way of designing the flap. Can you do that? Is there any change in the orientation of the flap which will help you to cover this defect? It's a just hardly 4 centimeter, 2 centimeter linear defect in width. Can you do something else? Can you use that little incident into play to close this defect? Is it possible? The most probable cause of giving away this suture line is, one is not proper suturing has been done. There must be tight closure over the implant. Implant must be big in this area because you have limited skin for that. Second is, as Mokal sir said, that vascular issues might be there with the skin edges. So this is not a big defect actually, width-wise.
Yes.
So can you modify your plans so we can have a better options? Okay, anyway. So what do you do for the linear defects in the leg? Suppose you go to the OT when orthopedic surgeon is operating and he said that this wound is not closing. So what do you do in that situation? You straightforward go for the flap, or you do some small maneuver, which is not possible here. I'm just asking because it's a scarred area.
For small linear defects, we can plan for a keystone flap.
Keystone flap, yeah, well, that is an option. But even before the keystone flap, what you do? You just give a
Relaxant.
Orthopedic
Give a-
surgeons are very fond of it.
yes,
They will do it before asking you
exactly.
and spoil the possibility of 2 other flaps.
Yes. So that's why your role
Is
here is
it
very
what?
important.
It's a release incision.
Yes. So if you release, it is always better. Release should be done by the plastic surgeons. So you release it like that your future options should not be jeopardized. So if you don't know this, then it will be because it's a linear defect. It's not a big defect at all.
A few things came out very strongly in this patient. The first is that why did this wound open up? And perhaps Nitin is right. There is an underlying vascular anomaly. Because why blame a surgeon? Let us presume that it is. Secondly, you said that there was obvious infection. There was purulent discharge. So certainly you cannot do a one-stage surgery in this patient. You have to do a liberal debridement, follow it up with a vac with the fluid therapy, so that it washes away all the exudate. Give it a week's time and then come back. You will get a better looking wound and then do your definitive surgery. I'm not very convinced about your reason of doing a fasciocutaneous flap. I think Professor Aniraj is absolutely right. A linear defect like this would do much better, particularly in presence of infection, with a vascularized gracilis. A beautiful vascularized gracilis will take care of everything. It's a wonderful flap and it gives very good results. But most important thing is, when you do a debridement, ask your orthopedic surgeon to be with you. Let him remove this plate and confirm that there is no dead bone. Otherwise, revise his osteotomies and if necessary, collapse the bone. It can always be addressed at a later date. But we need a bony union. With dead bone, there won't be any union.
Yes.
So Sandeep, what you have learned from till now with the discussion with all the examiners. So what is now, can you summarize what we have discussed till now?
One is to avoid any perforator if at all it is in the zone of trauma or the local flap.
Just don't jump to the flap first, like the debridement as sir said. So first you look for the possible causes. Why does it happen? Always give a always think about that. Why does it is happening? If there's a clear-cut infection or vascular issue, then so always look for the possible cause first, debridement, and then go for the surgery definitive plan. The problem here is you directly jump to the plan. You have to understand that, and which is bound to fail, because if there is any infection underneath, you will be having a sinus and a lot of issues in the future. So that is the key here. You have to understand proper debridement is must here. Surajit sir, Mokal sir, please.
Sir, we consulted an orthopedic surgeon over here, sir, by presenting the same case to him. He suggested that the implant will most probably be required to be removed, followed by asphyxiation and immobilization of the ankle joint. And he also suggested rush nailing for the fibula, because according to him, based on the deformities preoperatively, the ankle stability is an issue post-operatively. That's why he suggested an X-fix and implant removal. So,
Okay, that's fair enough. But you cannot do flap in the first sitting then. Because if you're removing the implant and you're putting external fixator, if you're so concerned about the infection, so why you want to put a flap directly? You want to check for rule out the infection status there, no?
Yeah, better to do in stages. First remove the implant.
Because if your orthopedician is so convinced that he has to remove this implant and take out the loose bone, that's okay. And if suppose this patient is, I say, 75-year-old lady and multiple comorbidities, and she's not allowing us to do any flap. Anesthetic is saying, "No, you have to just finish it up within half an hour. No, don't do any free flap and anything else." So do you do anything else? Suppose there is a defect of 2 centimeters, 3 centimeters.
We can place an
I'm just giving you a hint.
and,
Or not really. I'm talking about the surgical thing on the table. I'm just giving you a hint, 2 centimeter, 3 centimeter bony defect. You debride it well. You're sure there's no infection. You just put a bag, and just next time you went in, there was anesthetist is saying, yes, just finish it up. I don't have much time. You just can't continue the surgery. You finish it within half an hour or 1 hour at the max. So can you do something else?
Long, narrow defect in leg. What is a reverse dermal flap?
And who described it? It is also called as a turnover flap.
So in that scenario, yes, you look for the perforator and go ahead with that, because it will give you a better idea of that, because that was described way back when we were not having the knowledge of the perforator. So right, then the knowledge of this perforator come in between. And suppose there is a 3 centimeter bone defect, can you think about the shortening and close this wound primarily? Is it possible?
yes.
What, yes, sir? What is the upper limit of shortening in a leg?
not more than 3 centimeters, sir, because of the more shortening or docking will lead to the kinking of the vessels.
Yeah, you're right. Whatever can be corrected by a footwear can be shortened, nothing more than that. Otherwise, we'll have to lengthen it also if by laser.
In the chat box, there is one suggestion that can you use the skin closure device?
Sorry, sir.
It does
Have
not
you
affect-
read about the use of skin closure devices?
dermotaxis. That is what they are asking.
And the lower third of leg is the last place to use them.
We are not aware.
The paper is from Israel. Okay. So these skin closure devices, they are like the ratchets which the airlines guys use when you don't have a lock in your briefcase. You have seen them using a colored ratchet. They bring it back and then they pass the tail through a small loop, and then they start tightening it, and the ratchet goes chat, 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 and eventually it shuts off. Have you seen it? You can't open that ratchet. You have to cut the plastic. Then only it opens. The
Yes.
skin
Yes.
care devices work on that principle. The loop is on one side, the ratchet is on the other side, and they gradually, every day, try to close it gradually. The concept is histiogenesis, distraction, histiogenesis. But lower
Sir,
third of leg is the last
Yes.
place to use.
yes. And second thing is, sir, underlying bone is fractured. So will we do it? Will you try to do it? That is a major concern here, because we may have to go because there's a high chance of infection there, because bony infection, if we wait and keep the wound exposed for a long time.
Okay. So
Vishudha, anything else that we are forgetting?
Just a minute. Yeah. You see, Dr. Gawa gave you a hint that if suppose you find 2 centimeter more proximal another perforator, good perforator, away from the zone of trauma, then what you could have done a simple procedure, because a lot of tissue on the cuff is there. Any other flap you like to think of? A simpler flap? If you get a good pulsatile or a good perforator there, then can you think of any other constituent of flap which can be used, especially for this narrow defect? That's one question. And second thing is, if you see this picture, the whole implant is not exposed. There is about 1.5 to 2 centimeters of tissue bridging the in between. What is the significance of that? Because when you debride, suppose example, then you have to debride the whole thing,
yes. Yes.
isn't it? So make it absolutely raw. And suppose taken as the implant, every full debridement has been done, you are satisfied, and you want to give a primary flap, that's a different issue. But that bridge of tissue, which looks as if it is a granulation tissue, but while debribing, would you like to remove that part also and expose the whole implant?
So we are planning to remove the implant. That is also going to be exercised.
No, I'm not talking of planning. Suppose I stay with you that you don't want to remove the implant.
Okay.
So during your debridement, will you keep that granulation tissue part or not? Or will you excise the whole thing? Nicely debride the everything. Make it absolutely fresh. The third question is, when the orthopedician must have closed this, what went wrong? Repeatedly it is being asked. what was the cause of wound dehiscence? One is, of course, lack of mobility, local tissue trauma. Any other reason which sometimes they ignore? Is a hematome. Is a hematome. And when they put an implant, some of them like to put a drain, some of them don't like to put a drain. But if you put a drain and if you think that it is patient is hypertensive, as you have said, then perhaps that hematoma evacuation would have helped. Continuous drainage of hematoma. That is the third thing which I wanted to make. And is there any scope of, in spite of all this, because the wound is not too big and adjacent area, healthy area is also seems to be there. Would you like to do more simpler technique? Is it anything available? Is it always necessary to plan one flap, one local flap?
No.
I think I have given you enough hint. And because it is a narrow wound, adjacent tissues are available. Is it necessary that always you plan one flap? And the last question is that in your sural neurocutaneous flap, you have narrowed the pedicle, isn't it? Because the calf is wide proximally and gradually it's a balloon-shaped flap. You narrow the pedicle. Is it to your advantage or disadvantage?
The minimum width of the pedicle that has to be taken should be at least 6 centimeters.
3 centimeters on either side of the
On
axis.
side of the axis.
What I am asking is, narrowing of the pedicle helps you or it causes problem?
Having a
You have a perforator, good perforator at the base, and you are narrowing it. Is it going to help you or not?
Yes.
How?
The arc of rotation.
It will be easier to rotate the flap
Flap
to
is-
cover the defect.
Yes, you can more easily rotate the flap or move the flap without causing kinking at the base. Thank you.
Thank you, sir. If the panelists allow, can I move to the question and answer session from the?
Yes.
Yes, sir. Yes. Yes, Dr. Rohit.
Okay, sir. Okay, sir. Sure. Now, question and answer Q&A session. Team 1 from Madras Medical College. Please from Madras Medical College. Do you have any questions to the presenting team? Team 2, Jipmer Pondicherry. Team 2, Jipmer Pondicherry. Next, Team 3, KGMC Lucknow.
Hello. Who has first described the reverse sural artery flap? Hello.
Yeah.
Please, if you know the answer, say yes or no. Don't be silent.
No, we don't.
We don't know.
Okay, Musculate et al. In 1992.
Okay, next.
Okay.
Team 4, Stanley Medical College.
My question to you is, what is perforator compression test? Hello?
Yes, you're audible.
Yeah.
Sorry, we don't know.
A perforator compression test is how you identify a reliable perforator on a handheld Doppler. So usually the Doppler probe is placed perpendicular to the axis of the vessel, and we already know the anatomical location of the perforators. So the perforator signal will be intermittent, unlike the axial vessels, which will be continuous. And once you have identified the perforator, providing compression over the perforator will diminish the acoustic echo that will come, and as you release the pressure, the echo will increase. So that is how we identify or differentiate a perforator from the axial vessel. Thank you.
Thank you.
Okay. Questions from team 5, AIIMS New Delhi.
Can you explain what is dangling protocol and then why is it necessary in case we do a free flap?
We don't know.
Okay. So usually in normal limb, because of gravity, there will be a rise in capillary pressure, increase in the interstitial edema, and there will be venous congestion. So there will be the stress receptors which are present on the veins. There will be a veno-arterial reflex which will be initiated, and it will help to the signal. Reduction in the what happens with free flap that's done to the leg is all these compensatory mechanisms are lost because there is no sympathetic innervation, there are no muscle pumps, or there are no collateral flow. The VAR reflex is also not there. So in such case, we are conditioning the flap to gradual venous ischemia. So we do a dangling protocol. So there are a lot of studies which says it can be started on POD 3 or 5 or 7. So usually we do it from POD 7 or 10 onwards, and then like on the first day for 15 minutes, only once, then next day 15 minutes 2 times, then again for 15 minutes 3 times, then we gradually increase the time to 30 minutes once in a day, then 30 minutes 2 times in a day. So that is how we condition the flap for venous, increased venous, this one. So that is the dangling protocol and the reason why we have to do it. Thank you.
Now, any questions from team 16? Team 6, sorry, Bangalore Medical College.
Good evening. What is flap delay and what are the types of flap delay we commonly perform?
Flap delay is the ischemic preconditioning of the flap. It might be a medical delay or surgical delay. Surgical delay, it is of 2 types again, standard delay and strategic delay. Strategic delay will be accessing to the axial vessels and will be ligating the perforators. And the standard delay will be making an incision and elevating the flap in the facial, subfacial plane.
Yeah, thank you. Correct.
Next, team 7, CMC Medical College, Christian Medical College, Vellore. Next, team 8, PGs from Safdarjung Hospital, New Delhi.
Can you tell me about the complete classification of flap based on the 6 C's and whether you know who gave it, who described it?
6 C's. You're talking about 6 C's, right? Hello?
Yes, the 6 C's.
Yeah. So the 6 C's basically stand for circulation. First C is circulation, which mentions the vascular supply, can either be direct or indirect. The second is the constitution of the flap, which consists of what components are used in making the flap, whether it is fasciocutaneous, musculocutaneous, or any other components. Next is the contiguity of the flap. Contiguity corresponds to the location, that is whether it is going to be a local flap or a regional flap or a distant flap. The fourth is construction of the flap. Construction corresponds to the use of whether it is pedicled or bipedicle or unipedicle, whether we are using sensate flap, and next is the
conditioning of the flap.
Conditioning of the flap. Conditioning of the flap refers to
Supercharging, turbocharging, and what?
or whether we are doing a delay or whether we are using tissue expanders. And the last is the conformity of the flap, which refers to the shape of the flap, whether we are making a tubed flap or we are using it without any conformational change.
Pre-lamination, prefabrication.
And who described this?
Sorry.
Okay, this was called as a complete classification of flaps, and it was described by Halep.
Sorry, we're not able to hear you.
Halep. This was called the complete classification of flap, and it was described by Halep. Thank you.
Thank
you. Team 9.
Good evening. Yeah, RML Delhi.
Right.
Yeah, so could you just tell what type of flap is ALT according to the Cormack-Lamberti classification of fasciocutaneous flaps?
It comes as type B, according to Cormack-Lamberti.
Type?
Type B.
It's a fasciocutaneous. We don't take any muscle or bone along with it, so
yeah,
it is typically type C because it's considered to be based on the segmental perforators of the descending branch of lateral circumflex artery. So it's type C.
Team 10, Gandhi Medical College.
Hi, Team Gandhi here. So can you tell us about the lateral supramalleolar flap, its constituents, its indications, and vascular supply?
The lateral supramalleolar flap is basically based on the peroneal perforators.
It is based on the anastomosis between the peroneal perforators and the
Peroneal.
It is indicated for the dorsum of the foot defects and all. It is a fasciocutaneous flap.
Yes. So constituents is a fasciocutaneous flap, and indications medial lower one third of leg, heel, mainly posterior part, ankle, and dorsum of foot. And vascular supply, it is based on the anastomotic arcade around the ankle, mainly by perforator from peroneal artery, that is just above the giving out from the interosseous membrane above anterior tibiofibular ligament. And also one more main artery is anterior lateral malleolar artery from ATA. Yeah, thank you.
And Team 11, Kilpauk Medical College. PGs from Kilpauk. Moving to Team 12, PGs from MAMC, New Delhi.
Good evening, Mamsi. Can you please tell me the classification of keystone flaps?
Sorry.
Hello.
Sorry.
Hello, am I audible?
Yeah, we are not aware of the classification of keystone flaps.
Okay, it's okay. There are actually 4 types. Type 1, we give only skin incision. In type 2, there is 2A and 2B. 2A, we divide along only deep fascia along the curvilinear border. And 2B is we divide deep fascia all along and we skin graft the donor side. And type 3 is double opposing. Type 4 is 50% of subdermal undermining. And there are also varieties of like omega variant and Sydney melanoma unit variant also. Thank you.
Whose classification? Whose
Behan's
classification is this?
Behan, sir. BEHAN.
Felix Behan.
Behan.
Felix Behan.
Behan, sir.
Yep.
Thank you, sir.
Team 14, PGs from Ganga Hospital, Coimbatore.
Hello, good evening. So what are the contents of tarsal tunnel and what 2 nerves will you see in the tarsal tunnel?
We'll be having the tibialis posterior EHL and EDL along with tibial nerve, which will be dividing into the medial plantar and lateral plantar nerve along with posterior tibial nerve.
You also see the medial calcaneal nerve.
Yeah.
Thank you.
And team 15, PGs from AIMS Bhubaneswar.
Good afternoon. My question is, could you please elaborate on Godina's rule for soft tissue cover over lower limb defects?
Sorry, we are not.
So initially, before Godina came up with his philosophy, people used to advocate that early soft tissue cover is required. Godina further reaffirmed on this thought by saying that adequate debridement should be done within 72 hours of injury. That along with a good soft tissue cover would lead to a good successful outcome, clinical outcome. However, over the years, there was some criticism, but as of now, in the recent articles as well, we do follow that an early debridement within 48 to 72 hours would lead to reduced flap loss. Thank you.
Thank you.
And final team 16, PGs from AIMS Rishikesh. Team 16. Okay, sir. I would like to wrap this up. If panelists allow, can we move to the next part of the session, sir? Like spotters and instruments. And I request Michelle and Sandeep, please stop sharing your screen so that I can share mine. Thank you. Can you see this?
Yes.
Okay, fine. Your allotted time is 10 minutes.
Who sir can take this?
What is this? Can you elaborate the condition?
This is a case of left-sided hemifacial atrophy with a microtia, sir.
Is it hemifacial atrophy or something else?
It is not called hemifacial atrophy. What is it called?
Yes.
Hemifacial microscope.
Yeah.
And we don't even call it hemifacial anymore. It is craniofacial microsomia, unilateral and bilateral.
Yeah.
We have stopped using the word hemifacial ages ago.
Yeah.
So what is the deformity you see in this patient? Can you describe the deformity?
Yes.
There's hypoplasia of the left side of the mandible and the left ear.
So what happened to the left ear?
Is maxilla normal in this patient? Hello?
No, it also appears to be atrophy.
Why this maxilla is looking atrophic? What is the reason?
I think you're using these terms very loosely. What is an atrophy? What does the word atrophy mean? These are not interchangeable words. You cannot call something hypertrophied and atrophied just like that. If something has not evolved congenitally, will we call it an atrophy? What is wrong congenitally? What is the embryogenesis of this condition? What is another name of this condition? That gives you the embryology. First and second branchial arch syndrome. So all structures developing from first and second branchial arch are affected. So what are the structures which grow from the first branchial arch? Think about bone, think about soft tissue, think about organs. Developing from first branchial arch, developing from second branchial arch.
We don't remember.
Anyway, just describe the deformity. What is the deformity in this patient? And how will you examine? What are the examination findings in this patient?
Hypoplastic left side of the face, sir, with involving the maxilla and the mandible, with deformity of the left ear.
Any other deformity in the face? About the maxilla and mandible, what you look for when you do any intraoral examination? What you look for?
If I ask this child to bite into a wooden scale and you are sitting in front of the child, what will it appear like?
Sorry.
The child is holding a 6-inch wooden scale in between his molars. What will it look like?
What is called as a dental relationship? What that word called as? What do you see in the mouth?
Occlusion.
Occlusion.
Yes. So occlusal.
What is the occlusal?
Occlusal
cant.
Why there is
Occlusal
occlusal
cant?
It is a pathognomic sign of hemifacial microsomy. Why there is occlusal cant? Because left side zygoma, this side maxilla and mandible is not developed. Right side it is developed. That is why there is a tilt. So all these skeletal corrections required in later date. So this is a skeletal deformity. What about the soft tissue deformity you observe in this patient?
The left-sided ear is not well developed.
That is ear. I am talking about the face. What is a facial deformity? Any nerve is affected in this type of patients?
Facial nerve is in.
What does facial nerve do? If facial nerve is affected in childhood, what happens to the face? What happens to the muscle?
There is atrophy or poor development of the facial muscles on the affected side.
Yes, you see now, you're seeing that second picture, the first picture, you see now, there
Yes.
is less developed muscle, less developed soft tissue. Sometimes these patients are also associated with clefts. What cleft it will be associated with? And what it is called as, which number cleft?
Not sure, sir.
Huh?
We're not sure, sir.
Cleft 7. Cleft 7 extending from the angle of the mouth till the ear.
To the tragus of the ear.
That is cleft 7. You have not read this deformity, I think. This is very commonly asked questions if the patient comes with the ear deformity. So do you know what are the classifications of hemifacial, craniofacial microsomia? You know the classifications of ear.
Actually, seems they are not prepared for this. No? They must not have.
Sir,
read
can you
properly.
move to the next part, sir? 10 minutes, allowed to 10 minutes. Over.
Over?
Yes, sir. Next imaging. 10 minutes only, sir, for every spotter and imaging and everything.
Okay. You keep a time, huh? We don't have a time.
I am keeping track of time, sir.
So please describe this X-ray.
This is an orthopantomogram showing the maxillary teeth and the left mandibular, and probably a post-operative X-ray with right hemimandibulectomy, sir.
What about the hemimandibular?
Hemi? Is it hemi?
Is it hemi or something else?
The central incisor is seen over here, sir, of the right side.
But I can see the two incisors. So I will still call it a segmental.
Segmental man.
The menton is there. You can see the menton.
Yes.
And what about the upper alveolar arch? Is it complete? Or that is also...
So how will you reconstruct this patient? How will you go about it?
For the reconstruction of mandible, the flap of choice is free fibular reconstruction. sir.
Array, don't jump into
Hold
the
on,
flap.
hold on. First of
Just
all, you have to
plan.
describe what is the defect. What is the defect?
It is extending from the parasymphysis to the
Condyle.
condyle. Yes.
Yes.
To the condyle.
How will you go about it? You want to plan the case, you are just jumping directly onto the reconstruction part. Don't jump. First of all, you have to plan the case. How will you plan this case? Do you require any other investigations?
Obviously, it is
think of
going to
a
be a
better
secondary
imaging
reconstruction
technique?
because you are seeing the OPG after the surgery or after the trauma. So it is a secondary reconstruction. So how will you plan it? It is not on table picture. So think now. You think I'm just giving
You
you a hint.
require any other investigations to plan your surgery?
Three-dimensional CT of the
3D CT with 1 mm DICOM data to prepare your stereolithographic model and see how much amount of bone is required for the reconstruction. And you can do a mirror imaging for planning your implants. You can use that data to transfer that data into your fibula to do the osteotomies. These are all recent advances. You have to read all these things.
Are you following what Nitin is saying?
Yes, sir. Yes, sir.
Are you following what he is saying?
Yes,
Yes, sir.
We are doing a CAD CAM, getting a better idea of the missing mandible from the mirror image of that bit of the mandible which is there and recreating one. And on the basis of that recreated model, how do we get that model? What is it called? What is that investigation called which gives you a model in your hand? It starts with S.
I just mentioned it.
CAD CAM.
Stereolithographic.
Stereolithography. By stereolithography, you get a model in your hand. And when you have a model in your hand, you know that how much of your fibula is required and how much of it has to be used as a double decker. Because the fibula will not give you the entire height.
Yes.
And then you can plan the exact amount of mandible, and perhaps you have to do something for the condyle.
So how do you plan it actually? So you do a CT scan. How will you proceed? You do a CT scan with the 3D face reconstruction in DICOM file. So how will you proceed then? How you will reach up to the stereolithography model or CAD CAM or 3D printed model? Do you have any idea? So you convert DICOM to the STL files and give it to your, and you can do the even virtual surgery. These are the recent advances. I think you should know about this. Even I can't say it is recent now. It is already very well in practice for last 10 to 12 years. So it is, even you can't say it is recent. It helps you. You mirror opposite side to the defect side. And then you will come to know how to create a symmetrical mandible or maxilla, whatever. Okay. So what are the defect you are suspecting here? How many segments you will be you have to reconstruct for this case, and how many osteotomy you are planning to do?
3 segments and 2 osteotomies, sir.
What are the segments? Just name the segments.
First is symphysis to the
As Surajit sir has already said, I think part of symphysis is there.
Parasymphysis to the body, a body to the angle, and angle to the ramus and the condyles.
Okay, so you want to do 2 osteotomies, one at the body at angle and angle to the
parasymphysis.
Okay, so you want to do 2 osteotomy there. So what should be the minimum size of the segment which you can have between the 2 osteotomy in a fibula?
2.5 centimeters is the minimum distance between 2 osteotomies, sir.
Why?
Distance between the perforators that supply the fibula.
Oh, is it so? Fibula is supplied by the perforators?
No.
What kind of perforators?
No, sir, it is supplied by the nutrient artery.
Oh, nutrient artery? Oh, really? Once you do the osteotomy, nutrient artery will cut. Proximally, it will supply only the proximal part. Distal segment won't have any nutrient supply. So how much the distal segment get vascularized?
Yeah. How the fibula gets blood supply.
You are right. It was a type D flap always.
There are two types of supply, endosteal and the other one is
Periosteal.
Yeah.
Endosteal means
From the inner aspect of the bone.
so
Nutrient
how
duct.
come it comes?
From the nutrient duct.
So that is intact up to the proximal segment, because once you do the osteotomy, that is going to be cut.
Yes.
So now your distal segments of the fibula, they are surviving on the periosteal supply. So how does this periosteal supply is going to that particular segment? What is the good about fibula? Why does it happen? Does not happen into other bones? Why can't we do so many osteotomy in fibula? Are you getting me?
Yes.
You can't do these osteotomies to all bone. You cannot do it to any other bone. I see.
So the vessels supplying the periosteum, they're at a distance of 2.5 centimeters, sir. So that is why the minimum length of bone that can be saved, that is taken for a osteotomy is 2.5 centimeters.
So you will keep an intact periosteum between two segments? Is it must?
No, sir.
Okay, very good. Why? Because periosteum is getting
Separate,
segmental branches from the which vessel?
Peroneal vessel.
So peroneal all along with the fibula, and it is giving multiple branches to the periosteum continuously, segmental. So as you rightly said, that's yes, 2 centimeters is the minimum distance people say. So we should be keeping at least 2 centimeters of.
Okay, so can we move to the next part? Next.
But 3 pieces of fibula will not help. You will need a 4th piece which has to act as a double decker. Otherwise, you will not get the height. Yes, we can go to the next.
What is this?
These are instruments that help in carving the cartilage, sir, in
Okay.
basically creation of framework for microtia.
So what is the age for this surgery? At what age you do the framework insertion, autologous? This is a congenital issue. So when you will operate in a kid, what the age? What should be the age of the?
Between 8
Really?
to 14.
8 to 14 years.
8 to 14 years. It's a range. It's a big range.
So what are the techniques?
Because there are 2 popular techniques, and now third one has emerged. So both are doing at the different age. First of all, you have to tell at what age. Only then we can ask why. If you don't know the age, at what age we should do it, then there's no.
So what are the popular techniques for microtia reconstruction?
One is Brent technique and other one is Nagata technique. So Brent is a
Yes.
4-stage technique. In Brent, in first stage, we'll be creating the framework. In the second stage, we'll be
First of all, you should tell when Brent operate on these childrens and when Nagata operates.
At what age Brent operate?
What age? First of all, you have to tell the age. That is more important here. And then why we are waiting up to that particular age? Why we don't operate them at 2 years? Why don't we operate them 3 years? Everywhere we are talking preschool surgery. It will impact the children's psychology and all that. Why we are not following that criteria here?
Because of the lack of growth following framework creation. So
But what age for Brent? At what age? So you said 4 stages. First stage, when will you do?
If you don't know, say sorry so we can move forward, because there is no point wasting time like this. I think so. If you know, you know it. If you don't know, you don't know it.
Yes.
Okay, Nagata, at what age you will operate? Nagata.
We don't know, sir.
Okay. So these are the ear carving instruments. This is a carved framework. These are the metpos. So there are two techniques most commonly used, Brent and Nagata. Brent is from California, Nagata is from Japan. So one guy say 6 years, other say 8 to 10 years. So now you have to find the reason. I'm not going to tell everything here. I think you have to read about it. This is a very important thing. Okay.
Yes.
What are those implants? Nasal implants? On the right hand side? These are the silicone nasal implants, no?
Yes.
Have you used it anytime?
No, sir.
Been using it anytime?
No, sir. We haven't.
Suppose you don't have any donor site to augment the nose, and if you want to use this silicone implant, what are the instructions you will give it to the patient? What you will tell to the patient if you're using going to use the silicone implant? Common sense. It's a silicone implant. It is a foreign body. Anytime this is going to give you trouble. So better to use autologous. That you can tell to the patient. And if you want to use this silicone implant, what will be the route of insertion? Have you heard of silicone augmentation of the nose?
Yes.
Huh?
Yes, sir.
What will be the route? Which incision you will take to introduce this L-shaped silicone implant into the nose?
Not sure, sir.
Hmm?
We're not sure, sir.
Not sure. Not seen any time.
Yes.
You should take a rim incision, then dissect between the two domes of the LR cartilages, then go on to the nasal dorsum in a subperiosteal plane.
Okay,
Your implant should be placed in a subperiosteal plane so it doesn't move. And this columnar extension, you go dissection between the two anterior crura of the alar cartilages. Create a pocket so that the central part rests into that area. That is how this implant is placed, dorsal and columnar strut. Okay. What is that lower part? Which implant? This is also silicone implant. Do you know silicone genioplasty? And what are the roots? You see that the lowermost, which is the silicone chin implant, no?
Yes.
Yes.
Have you seen silicone genioplasty being done anytime?
No.
No.
What are the roots? You can go by intraoral route or you can go by submental route. Some people prefer to go by submental route. You dissect till the margin of the mandible, create a plane in the subparietal plane, and then insert the implant on both the sides, and fix the implant to the periosteum with the stitch. Okay. Some people prefer to go intraorally. If you want to put intraorally any type of implant, now whether it is silicone or it is Medpore, what precautions you will take? Where will be your incision in a intraorally?
At the gingivobuccal sulcus, leaving a margin of 2 to 3 mm from the alveolar margins.
Yes, and then
we go perpendicularly up to the periosteum and then elevate the periosteum and then place the implant. We have to make sure that the nerves are which the mental nerve which enters the mandible near the canine is safeguarded before creating a subperiosteal plane.
very good, very good.
Yeah.
So,
So what are the?
So this incision stands true for all the intraoral exposures of the mandible. Okay.
Yes.
Yes, Sunil, go ahead.
So what are the pros and cons for intraoral and extraoral approach? Because few people use extraoral approach and few use intraoral. So how do you decide which to go and what is the benefit of each? Can you tell?
Extraoral, there will be visible scar.
Yes, good. But the benefit, what is the benefit? What those are doing extraoral? They are just giving a small scar under the chin, which is not really visible. And what is the claim they made? It's office procedure. And what is the common issue when we go intraorally?
Possibility of infections are high.
Yes.
And if the incision is not closed adequately, we might
exposure of the implant is also high.
Yes. So these are the issues you should be knowing. Mukul sir, the upper white one implants, is this Medpore implants? What do you think? I think it looks like Medpore implants.
No, all look like silicone to me.
Okay.
All look like silicone to me. Anyway,
what is Medpore implant?
You know about Medpore implants?
No.
You never heard about Medpore? And what is its pharmacological contents? We'll get a short note, huh? Different types of implants. Porous polyethylene is Medpore.
Okay.
Have you heard about a bony scaffold? Bony scaffold. Porous caprinolactate. Have you heard about it?
Sorry to interrupt, sir.
Yeah.
Can we move the time?
Over? Okay, next.
Okay.
It looks like
The diagnostic?
Dupuytren's contracture, sir, involving the ring finger.
So why does it happen? Any predisposing conditions or anything related with this? What commonly we ask in the history for these patients? Okay. Leave it. If you don't know, leave it. How to proceed in this case?
Surgical by excision of the palmar fascia, so the affected palmar fascia.
Straightforward.
There,
So what all structures are affected in this?
The palmar facial.
nutatory ligament, spiral cords, Clinard's ligament, all are involved. Lateral bands are also involved.
So what are the tests you do before proceeding in these cases? So because there are a lot of procedures are described, you
Yes.
can you name the procedures and when you do the particular procedure for this condition?
Medial fasciectomy or limited fasciectomy or radical fasciectomy and
when there is a pit in the skin, what do you do exactly?
dermatofasciectomy.
Yes. So these are the few procedures. So how do you decide which one is appropriate for the particular gentleman?
Based on the severity of the contracture forming.
So how will you
How do you
stage it?
decide? Okay, what is tabletop test?
So,
do you know what is tabletop test?
Tabletop test.
Because you can do percutaneous needle fasciectomy, you can fasciectomy, you can radical fasciectomy, you can dermatofasciectomy, but how will you decide it? Because it's the common issue with this technique, this disease is there's a high chance of recurrence. So you don't know what is table test. Okay. So if you do percutaneous needle fasciectomy, what should be the size of the needle?
.26 gauge needles.
Yeah, that's right. 26 gauge.
What are the other
You do-
sites you look for?
Sir?
What are the other sites you look for in general examination in this patient?
It can be associated with other diseases like Riedl's thyroiditis, retroperitoneal fibrosis, or Peyronie's disease of penis.
Okay.
So what sort of incision are we going to give?
Brenner's incision will be giving.
What incision is it?
Brenner's.
Okay. What is the tissue that we are going to excise?
We'll be excising the thickened facial bands.
Deep palmar aponeurosis and surrounding bands.
Yes.
So what is the criteria when we will say that our excision is complete and the release is complete? Which brings us to this old question, what is the tabletop test? There's a contractured finger. When is the contractured finger completely released?
When all the restricting bands are completely released, and when we're able
And
to achieve the
how will
complete,
it show on the how will it show on the hand?
we'll
How
be
will
able to
it show
achieve the
on the
complete
finger?
extension of the contractured fingers.
And the dorsum of the finger will go down and strike what?
Surface of
The tabletop.
Surface of the
The
What-
tabletop.
What precaution you take while you excise this diseased fascia or ligaments?
We'll be taking care to preserve, to not to damage the neurovascular bundles.
What
And,
happens to the neurovascular bundle?
They'll be migrated medially. So while exercising, we need to preserve these nerves.
So how will you preserve it? Because they have migrated immediately. So how will you start? You will start surgery proximally or distally? That's a very important question. Got it? Migrated at what point? In the whole length or at a particular area? Because why it is migrated? Because your finger has got inflection. Once it goes into the flexion, because band is in the center of the finger, they are on the mid-lateral side. They are coming into the anteriorly. So at what location you have to be very, very careful when you are dissecting this. What is the easiest way? You start dissecting distally or proximally from where?
Dissect it
Because
from
there's
distal, proximal to distal.
yeah. So if you release it proximally, your finger gets straight. Those vascular bundle goes back to the normal position. So there is a less chances that you will damage it. Got it?
Yes.
Because they get volarly in the junction at the proximal interphalangeal crease mostly at this level.
So it is easy to follow the neurovascular structures. So what are structure, abnormal structures that displaces the neurovascular structures, you remove it. Okay.
If no more dissection, we can move ahead.
Yes, yes.
The counseling and operative session.
this looks like unilateral enlargement, sir, of the left breast. With a Phyllodes tumor.
So how will you counsel?
Sandeep and Vishal, be cool. Sir is asking, how will you counsel this patient?
So the possibility of a malignancy will first need to be ruled out, sir. So
is it malignancy or it is infected breast implant?
Infected breast implant.
Why not cystosarcoma phyloides?
Looking at the lateral skin, it looks very inflamed and red and tense. So
Okay.
So you decide on one diagnosis and go ahead with your plan. Hello?
Yes, sir.
They decide on one diagnosis and go ahead with your plan.
It looks like a case of infected implants, sir.
Okay.
Go with that.
Yes, sir. I'll explain to the patient regarding if as the implant is infected, it requires removal of the implant.
Okay. What you will do to the capsule?
We need to excise the complete capsule, sir.
What you will explain to the patient after removal of the implant?
We're not sure, sir.
This is going to be a very traumatizing thing for the patient. She never bargained for a infection. So it is almost a catastrophe. The first thing we do is reassurance. Everything will be all right. So the first thing would be reassurance. Then you will say, we will take care of it. I am taking responsibility. That makes the patient feel better. Reassurance, taking responsibility. 2. Then you will give her a reason that why it unfortunately happened. You will say, when we do several hundred cases, one unfortunate patient like this comes up. So, to the best of our knowledge, we have not been able to solve this riddle. But we are very cautious and we try to avoid it. That is why 999 patients go home without a problem. So these are words of reassurance that you have. The first thing is reassurance. Then how do you manage? Now it has happened. Tell me what are you going to do about it? You can't afford a thought block because the patient is relying on you. It has to be your ideas.
The implant needs to be removed, sir, since it is infected.
Fair enough.
So we'll counsel the patient regarding second procedure in order to remove the implant.
Not at all. Not at all. This is not the time to talk about the second procedure. This is the time to cure her of this catastrophe. So you will have to convince her that she has to undergo another surgery. And in that surgery, she will lose this implant, unfortunately, because that's a foreign body and it has become infected. It is of no use. It is doing harm to your body. So it needs to come out ASAP. What else?
The possibility of a mismatch between the size of the breast because we cannot place a second implant immediately as the infected one is removed.
Right.
So she may need to go ahead with either padded bras or any such cosmetic.
You are still not getting it. You have to convince the patient that you are going to treat her breast abscess. How you are going to do it, you have to explain it in her words. Like any other abscess, we'll have to leave this open for some time till all the infected material drains out. Then we will, at an opportune moment, do a delayed primary closure if possible. And we are not going to put an implant for how many months?
At least 3 months.
Perhaps 3 more months.
6 months.
Okay.
Suppose you have removed the implant and now our entire breast is collapsed. Lot more fibrosis around. Before contemplating any second procedure of implant, do you have something in your mind that you can improve that area with something else? Improve the bed, huh? With what?
We're not sure of the answers.
What are the things you do for improving the good bed? There are a lot of scarring. You want to give that area a supple area. You want to bring in the stem cells there. So what is the new thing which is there which will improve your vascularity in that area, improve the bed in that area for your secondary procedure?
PRP injections, sir.
Have you heard of fat grafts being used to supple your scars, to improve the area? Huh?
Yes.
Whose paper? Whose paper? The author of this work?
Coleman.
No. Fat graft, Coleman, yes. But this work to improve the condition of a scar, Gino Rigotti.
Okay.
Okay, next case. Anything else? Sunil, you want to ask anything else?
No, sir. Thank you. I think.
Any input, this patient? Yeah, this is.
Must be the last. Spotters.
Yes, diagnosis.
Sandeep, Vishal, speak up.
Benign hairy nevus of the face, sir.
Yes.
Congenital hairy nevus.
Congenital hairy nevus of the face.
So how will you manage this patient?
Serial excision.
We do serial excisions of the affected area in order to excise the nevus and send those for biopsies, sir, in order to rule out any possibility of malignancies.
Serial excision means how many stages you may require?
All 3 excisions with serially you can excise this, or she will require some other procedure also.
This
You are
involves
in
the
position to remove entire thing with serial excision?
Here the lower eyelid is also involved.
Are you understanding what they are asking you? Is there a limit to serial excision? Are there important anatomical landmarks which cannot be encroached by serial excision?
Yes, sir. Lower eyelid is there, so we can't.
Lower
So
eyelid
then
is
in
there,
that
perhaps
case,
the lateral canthus is there.
Yes.
So your
in
serial
that,
excision does not help. Think about
so
something else.
what is another method?
We can do a tissue expansion around and excise the lesion and then the reconstruction of the excised part.
Around means where will you place the expander?
Preauricular region.
Yep.
Over a bony prominence, so the preauricular area is the.
Okay, so you will put the preauricular region an expander here. So what is the drawback? What is the most common issue when you put at a preauricular region? And what is the recommended size you should put? Volume, sorry, not the size. What is the vital structure in the preauricular area?
Facial nerves.
Facial nerves.
So what happened? If you put an expander over it and over the period you inflate it, what will happen?
Compression neuropathy might.
Neuropathy.
Any
Neuropathy or
other
something else?
site where we can do it? Any other site can be expanded?
The forehead can be used.
Neck.
Forehead can be used.
Next.
You cannot compromise forehead. You have to place the expander on the cheek and the neck. So that you can advance entire cervicofacial flap.
Flap.
The facial flap transposes into the nasolabial area and the cervical flap transposes in the preauricular area. So that you will be able to cover entire defect.
Because if
Are
you
you
put in the
getting it?
neck.
Yes.
Are you getting it?
Yes.
You look at the patient once again. Fortunately, the medial border almost is parallel to the nasolabial fold. So the suture line which will fall there and along the lower eyelid perhaps is not going to be visible after some time because they are along anatomical landmarks. So this is an excellent planning which Nitin is suggesting. Are you appreciating it?
Yes. Yes.
What? Yes, sir.
And
Where will
make
be the
it a
final suture
habit.
line?
And make it a habit to say, I will use it, not I can use it. Can makes us think that you are doubtful. When you say, I will use it, we like it. That means that you are confident.
So if you put an expander in the neck, so where will be the final suture line will fall? Because that is very important here. That is the important thing actually. That's the play. Because if you put in cheek or in the preauricular region, then it is not going to serve purpose. So what type of flap movement you are having when you're putting in the neck? Are you getting me? Because when you put an expander, what kind of movements happen to the expanded skin?
Advancement of these.
So it is not only the advancement when you put in the neck. So what kind of movement is there? So you will have a better scar and better suture line in the end. Because whenever you're planning an expander, first you should be looking for the final suture line. Only then you always put expander rather than putting expander in the skin. It's not like that. So whenever you're putting a expander, you should always think about the final scar line and then plan the rotation or advancement of the flap. So if you're putting in the neck, what kind of movement you are expecting here? Only advancement or is it something else? I think sir has already said.
Look at the patient. You can see the defect that you will be creating. After that, you have some area of skin left on the cheek. Let this be one lobe of your flap. The base is towards the ear. Now from the submandibular region, take the second lobe of the bilobed flap. So when you suture it, the straight suture line of the second lobe will be hidden in the submandibular region, whereas this entire flap will look better. Are you getting it?
Yes.
I don't think so.
Are you getting it?
Yes or no? Yes.
Sunil, can you draw it on the face so that they can understand it?
Sir, I think
Farooq, can we draw it on this face and make them understand this?
Yes, sir. There is an option like
How to write? Is there option? Is there option?
yes, sir. Yes, sir. There is an option like you can choose the pencil. Yes, yes. Sunil sir is doing it.
If you can draw it, Sunil, please show them exactly what we are saying. Okay, while he is doing this, answer one question. This child is born today. The obstetrician has asked you to come to her obstetric OT and look at a strange looking child who has a black hairy patch on the face. What are your options? What are you going to do then? Have you understood my question?
Yes, sir.
This child has been born today. The obstetrician has called you in her OT. She is telling you, look at this strange looking child. She has got a black patch on her face. Can you do something about it? You're not reading our textbook. I'm so sorry. You are not reading our textbook. You take a wet gauze and start rubbing it off. It comes out and leaves a red skin only. The entire pigment and hairy area just peels off. You dress it with soffritule and leave it as such. The scar you are going to get would be the best that is possible in this patient. Did you know this?
Yes.
That is because you did not read our textbook.
So any other option for managing? Suppose the patient cannot afford tissue expander. Any other options?
Not working actually.
so. One way of is this: we can put expander in the neck and transpose it whole. We have to raise hold this flap like this, and this will go up, and this skin will come here. This skin will go here. One way is this: when we are keeping the base in the inferior lateral aspect, inferior medial. We can keep inferior lateral if we put, because there is no space in the neck picture, so we can put expander here. In that area, we'll keep base here, and we can rotation advancement from this side. But in that scenario, you will be having scar here. So if we put it expander in this area, so we will be having this much of the skin. This skin is this skin will go up here. So there will be some scar line. One scar line is here. The scar line will be like this. It will be going like this, and here. Like a facelift incision. Like in elderly, you do mustardy cheek rotation flap. So it is sort of that, but it is little bigger defect for that. So we need to put an expander in the neck, or we can use this skin to advance, because we will make a whole flap like this, because this is going to be excised. So the flap become like this. So here the movement is advancement. From here the movement is rotation. So we have two movements here, rotation and advancement. I will share a picture of the patient where almost similar patient where I did this, and how the planning has been done. So I think that will be better, because here we cannot see the neck here in this picture. That's a major issue.
Very nice. I can see some people in the chat box are saying that it is not possible to expand neck because there is no bony hard tissue behind. I don't think that is so. I have expanded neck many a time.
Because they
huge thyroid glands are enlarged.
no, they are expanders with a hard base. Actually, we are using expander with a hard base. There are a lot of expanders available with a hard base. So whenever you're putting in the neck, we are using an expander with a hard base. We don't use a spherical like a soft base expander.
Yes.
Okay, sir. Can we wrap up the session for today?
Yes. Yes.
Please wrap up.
Any questions from the delegates or any other faculty to the presenting PGs?
Any questions in the chat box which have not been taken?
Yes.
Vishuddha, any questions for them?
No, sir. And like
Such, there is no question. Only this expander was there.
Yeah, can I have?
Yes, sir, please.
Yeah. Somebody suggested 2 expanders, no? So, okay, suppose we go for 2 expander. What is the precaution you should take when you are using 2 expander in any situation? 2 expander you are trying to put. What will be the most important precaution you will take? I thought I'll make that point in my comment. Actually, whenever you use 2 expander, there should be a bridge of tissue between the 2 pockets. So that by chance, if one gets infected, the other is not affected. But at the time of full expansion and tissue transfer, then you don't have a problem of that small bridge, because that becomes very thin as the tissue expander expands. So the bridge between the two, even if you keep say 1 centimeter under direct vision, you are keeping it. So that becomes almost few millimeter after expansion, but it keeps 2 compartments separate. So that is the precaution you should take. Rest I'll make it in my comments. Because the expand, and the other thing is that when you think of expander, it's very easy to think that first of all, you should give all the options to the patient. That suppose you in one go you remove it and put an FTG, what will be the result? If you put an SSG, what will be the result? The answer is that it will also look like a patch. You have come for a darker patch, it will become a lighter patch. So FTG or SSG is not advisable in such case, because it's a thick tissue. So there will be a contour defect also when you remove it, the hairy nevus. Second thing is, most importantly, if you are using a serial excision, the greatest advantage is that it may be multi-stage, but ultimately you will have a linear scar. Of course, depending upon the vital structure, like here, the lower eyelid, it will be pulled in any case. So maybe the serial excision is not advisable, but that is how you convince for serial excision. And the third point is, when you are putting a tissue expander, 1 or 2, you have to visualize how many scars you are giving on the face. One is the suture line, and then the donor site. Whether it is a single transposition cum rotation or a biload flap. You must be able to calculate yourself before explaining to the patient how many scars you are going to give on the face of the patient. Would you like to have in your own face? So you must calculate. Your flap might survive everything. The nevus goes, but the patient does not give you much satisfactory result, because they say, sir, you have produced so many scars on my face. Nevus is gone. So you have to balance between those two when you think
So
of all the options.
Considering what you have just now said, will it not be a better option then to go for a super thin groin free flap anastomose to the facial artery, least scarring, and perhaps good color match?
Yes, those options are there. And the other thing which I wanted to say is, in this particular case, although it is said that you put the tissue expander through the adjacent normal area, immediately 1 millimeter beyond it, say in the lower border of this particular case, but maybe, mind keeps on thinking, maybe that lower 1.5 centimeter can be excised. And through that excision, you can put the expander.
Put an expander.
So that the size of the lesion becomes less. So ultimately, when expanded tissue expands, you might be able to do an advancement flap only rather than doing many other techniques, say bifurcation or whatever. So we must keep on thinking. In each case is different.
So another point with these boys should understand is the concept of the anatomical zones. Now, if the entire lower eyelid D is excised and we put a full thickness graft, and then the rest of it is covered by a flap, will that be better, or will a full thickness flap which goes right up to the lower eyelid will be better? That is something which has to be understood right away.
And the other thing is, when you are putting a transposition or advancement flap almost to the margin of the lower eye, you should be able to, otherwise it will drag it down. It will cause ectropia. It will cause ectropia. So you should be very careful how and at what place you are sort of stabilizing this expanded flap before advancement to the periosteum of the mandible, so that that dragging effect is gone, because we have two enemies. One is the dragging effect, other is the tissue memory.
Yes.
So even if you expand and keep it for say 1 month or 2 months, usually 1 month, 4 weeks, the tissue memory, we do not know when it gets erased and how much. So in this particular case, the lower eyelid, we may resurface it nicely, but that dragging has to be kept in mind.
And the anchorage has also to be provided in the zygoma, so that this flap stabilizes there. It does not drag. Are you getting it, Sandeep?
Yes, sir. Yes, sir.
Are you getting it?
Yes,
we
sir.
cannot just hang the flap from the lower eyelid and expect everything will be hunky-dory. It will not. The flap has a memory, the flap has a weight. And as days go by, the memory and the gravity is going to pull the lower eyelid down and we will get an ectropion. So we cannot plan such things. So it is better to take this D as a separate anatomical unit and replace it with a full thickness graft. And then go ahead and replace the rest of it with a flap, which is a separate anatomical unit. Or perhaps go by your first planning of serial excision.
Can I have a comment?
Sir.
Yes, please, sir, please.
Well, all the panelists have nicely displayed their roles, and they have nicely also asked the very nice questions. Only I have a comment to the organizers. The last documentation slide, which was meant for mostly documentation, because this has been a competition. So everybody should be in a uniform way of evaluations. So I think documentation means it should have been properly, a case should have been given. Anyway, it doesn't make a much of difference, but in henceforth in future, I think the organization, Rohit and others, and Farooq also, please keep a
Yes,
note
sir.
of
Yes, sir. Got
this.
it. Yes, sir. Got it.
Yeah.
Sure, sir.
Thank you,
Yeah.
sir.
Thank you
Got
so
it, sir.
much.
Thank you, sir. Rohit, can we move ahead?
Yes, sir. Regarding the panelist, final panelist remarks, sir, regarding the performance and further suggestions to make it more best. Now, I'd like to request Surajit, sir, to give
So
his
the
comment.
moral of the story is that you're doing well, but the fund of knowledge needs to improve. And for that, despite the worst and the most busy schedule of the day, you have to keep 1.5 hours, 90 minutes for reading the textbook. It is very important to read the textbook. It has to be read in 2 sessions of 45 minutes each. 45 minutes for the case that is going to be operated tomorrow, and 45 minutes we're starting a volume from page 1 to the last page. So the fund of knowledge is very important. Otherwise, if that is found lacking, the examiner starts picking holes. So very important to go back to the book. Thank you. You have done very well.
Thank you, sir.
Thank you, sir. And now, our second panelist, Nitin, sir.
Yeah, you required to read a lot. You should read our Indian textbook of plastic surgery, which is very, very well written and lot of Indian experiences. And you should read that book, Indian textbook of plastic surgery, Indian scenario, and everything, every detail has been given in that book. Lot of effort has been taken to come out with that book. So read that book. You should be updated with all your recent advances, like computerized planning, other things should be fit pat with that. So all that thing is required. Need to improve a lot. Need to read a lot. Okay. And try and attend most of the webinars which are being conducted. Try to attend lots of workshops being conducted. Attend rhinoplasty workshops, attend Mumbai cleft workshops. A lot of operative surgery workshops are being conducted. Please attend them. Okay. All the best.
Thank you, sir.
Thank you, sir. Now, I would like to call Sunil, sir, to give us feedback and inputs.
Good evening, friends. I think it was a great session, and Vishal and Sandeep, I think you guys presented your case very well. But I found that when it comes to craniofacial or any other areas, you are lacking there. So I think you need to improve there. And as Mokal sir said that you have to attend more the conferences and all that. That's true. And at the same time, you try to present some your work and discuss among your colleagues more and more, because it will give you the insight. And always, before going to the OT, just read about the procedure, and ask questions, become inquisitive, because I think discussion is the key here. You discuss more, you learn more. Because plastic surgery, when it comes to the plastic surgery, we have to be innovative, inquisitive, because these are the two things which really make us understand the thing. Because putting a free flap is the most easiest thing, I must tell you. That is the technical part, but planning is more important here. So I think, but you did pretty well. I think you are in second year or third year. I don't know in which year you are, but I think we need to discuss more and to attend more things. I think it was a great session. Thank you. Thank you very much.
Thank you so much. Now, I would like to request Dr. Anirudh, sir, to give his.
I like to know which year you are, final year or second year?
Final year.
Okay. Your case discussion, that part is, you have done very well. You have justification against your plan. But in other parts, you are lacking. I think you have to read more you have to discuss. You may need discussions more. And there may be variation in center to center, the pattern of cases you are doing, but still you have to learn basic things. So I wish you a good luck. Thank you.
Thank you so much, sir. Now, I would like to ask.
So I hope sir was saying at the beginning that it's a long session. Nitin sir was saying it is for 3 hours. I hope you must have enjoyed the session. Isn't it, sir?
Yes.
So I thank you all for participating here, for joining us, for accepting our invitation. So at the end, I request Sania, Dr. Sania, to present the vote of thanks. Dr. Sania is there?
Maybe she is not there, sir, due to some signal issues. I will give the vote of thanks.
Okay, you can. Please go ahead.
Before proceeding to vote of thanks, Bhattacharya sir, you want to give any final inputs?
Okay. In the leg defect, I'd like to emphasize on the students. You have already heard the panelists. Think of all the possibilities. You know, your thinking process should be very methodical. Think of local flap, regional flap, free flap, whatever, cross leg flap, because sometimes the examiner keeps on asking, what are your options and how will you select? So in this particular case, I feel personally that as Dr. Sunil was telling, that there may be a perforator higher up. So you can use even an adipofacial flap turnover, single stage. Or if you look at the local tissue, you might have two more or less random fatal flaps, one antegrade, one retrograde based on posterior tibial or peroneal. You feel the tissue. Feeling of the tissue is most important. Whether it is indurated or soft, you have to feel the tissue. So these possibilities you must keep in mind. The second thing is regarding Doppler. See, even audio Doppler, I have seen the world stalwarts, whatever they have found pre-operatively, the perforator might not have been there exactly. So it has its limitations. It is extremely useful. Most of the time it is successful. But if you don't find the perforator, maybe you will be able to visualize it nearby. But I have seen, I don't want to name them, in many workshops when they have isolated the perforator, they have made the audience hear the sound, but when he made the exploratory incision, it was not exactly at that. What is the accuracy? Then how do you decide the accuracy of the Dopplers? So there we have the audio Doppler, the color Doppler, and of course the exploratory incision. So if you scientifically think and with a research mind, the best way is that you do the audio Doppler and do a color Doppler of the same patient. That will sort of counter the findings of each other, whether they are exactly same. There may be difference. And at the time of exploration, you keep the colored Doppler plate in front of you in the operation theater. So you have Dopplered it, you have made a cross on the perforator, your colored Doppler is in front of you, and then you make the exploratory incision. And see how much all these three coincides with each other. That will give you an idea of the accuracy of the locations of the perforator. You must know about the implants and expanders, whether it is being done or not. Because in future also, if you opt for those cases, you might have to do it. So don't go that. Regarding deputous contracture, you have said most of the thing, but you have not talked about the incision. So there are various types of incisions depend upon the individual surgeon. But since there is a contracture effect on the skin also, it is good to think about, in such cases, the multiple Z plasty. That will give you adequate exposure. that will give you complete visualization of the deep palmar fascia, which is engulfing the tendons, and the neurovascular bundle, and therefore it should be done under at least loop magnification. So in the exam, you have to say like this: I'll do a multiple Z-plasty under loop magnification. I'd like try to see the tissue engulfing the tendon, and then after removal, you have to see how freely the tendon is moving. That is another thing on the table. You have to see it. And regarding the breast implant infection, if you see the case, the right breast was also not very well developed. Okay, so not maybe the patient as she wanted to be. So only unilateral implant has been given, and that got infected. So during counseling, you have to tell that also, don't worry, as Dr. Surajit was telling all the points absolutely correct, emphatically. And don't worry that your left breast will not be having smaller size than your right, at least. And later on, both can be inflated. Both can be, we can put implant maybe in the future. So that will give them, more satisfaction and more confidence. Okay, we'll have both the breasts together. We can do this. So these are the things which I just wanted to mention. Thank you for giving me this opportunity.
Thank you, sir. Thank you.
Thank you, sir. That's a detailed review.
Dr.
Now,
Rohit?
yes, sir. I would like to proceed to the final vote of thanks, sir. It's a privilege to give vote of thanks. First and foremost, I would like to thank Dr. V. Bhattacharya, sir, who is our chief patron and been the constant support for our Plastiquest from the beginning itself. And our overseas sponsor, Dr. B. Venkatratnam, sir, who is sponsoring this whole entire Zoom platform. And our PG mentor and organizer, Dr. Lakshmi ma'am, who is right now not here, who she is initiated this and started this event. And other organizers, Dr. Sandeep Vijayaraghavan sir, Dr. Radhakrishnan sir, and Umar Farooq Baba sir. And other co-organizers, my fellow co-organizers, Dr. Likita Reddy and Sanya Salim, and our PG coordinator, Dr. Srivalli Sandeep. And a special thanks to our panelists who spare 3 hours of their valuable time on a weekend. Dr. Nitin sir, very much thank you. And Surajit sir, and Sunil sir, and Aniraj sir, very, very thanks for you, sir. And our students who took all the beating from the panelists. I thank Dr. Vishal and Sandeep for coming forward and presenting this case and make this session possible. And all the other students who are participating and the delegates who are attending this event. And last but not the least, to the judges who are constantly observing and monitoring the whole sessions and judging the students. Thank you so much, sir. Thank you. Have a good day, sir.
Thank you. Bye-bye.
Thank you.
Thank
Okay,
you.
sir.
Thank
Bye-bye.
Bye.
Bye-bye, sir.
Bye-bye.